Hormonal. I'm Norman Swan. Welcome to this programme on looking after women around the time of their menopause. Menopause is a natural transition, or has it become over-medicalised? Why do we need to manage it? At a time when a record number of baby boomers in Australia are experiencing menopause, our experts tonight are going to answer these and many other questions of interest to you working in the primary healthcare sector in rural Australia. We've got a number of resources available for you on the Rural Health Education Foundation's website, rhef.com.au, but don't go there just yet because you've got to meet our panel. Jenny Bath is a clinical nurse consultant at Women's Health based at Tamworth Community Health Centre in New South Wales. Welcome, Jenny.
Thank you, Norman.
Jenny provides clinical and information services to women of all ages. She's also currently the Secretary of the Australian Women's Health Nurse Association. How many members have you got?
Oh, about 90.
90? That's pretty good. We need
Across
more.
Australia. We do.
We do need more, particularly in rural areas.
Absolutely.
Elizabeth Gallagher is an obstetrician and gynaecologist in the ACT. She's got a special interest in menopause and pelvic floor disorders. Welcome, Liz.
Thank you.
Liz also has experience in the Northern Territory with Indigenous women in outreach clinics in remote communities. Christine Reid is formerly a GP but now works as a sexual health physician and independent consultant in family planning and reproductive and sexual health in Lismore in northern New South Wales. Welcome, Christine.
Hello.
Christine is Honorary Secretary of the Australasian Menopause Society and has managed a number of innovative projects to address the lack of services and information in country areas for rural women and Aboriginal women. Last but not least is Dimitra Soukalis, who's a community pharmacist from Ascot Vale in Victoria. Welcome, Dimitra.
Thank you.
Dimitra has done locum work for 13 years in country and metropolitan pharmacies in both hospital and community sectors and served on various professional committees for the Pharmaceutical Society of Australia. She sat on state and national boards for the PSA. So welcome to you all.
Thank you.
Jenny, you see women coming through, ordinary women, nothing special, just women coming through with issues. Do you feel that their attitudes towards the menopause or even the symptoms that they come in with are changing?
Norman, I think it's changed in that women are more likely to talk about their menopause these days, and certainly women can be expected to live a lot longer after menopause these days, so it has certainly changed over the years.
So what's changed?
I guess the women's willingness to actually talk about their symptoms and to actually seek help.
Christine, I've heard that women have stopped seeking help because they say, well, there's no HRT anymore, I might as well just grin and bear the hot flashes.
Yeah, I think there's been quite a difference since the WHI
That's the Women's Health
came
Initiative
out. Yes,
randomised trial.
That was in 2002, and women got scared, and so did many doctors and nurses get scared of HRT, and they are coming in fewer and fewer numbers, but it doesn't mean to say the problem has gone away.
What's your take on that, Liz?
I agree with Christine in that I think there is certainly still women that are having problems that are actually starting to seek help, and in some ways I think over the last few years, as more evidence has come out after the WHI scare, showing a slightly more positive light, or at least giving us a lot more information, so we know the facts that in fact women are perhaps coming back a little bit to accepting HRT, at least in that perimenopausal.
What's the view
time.
from the pharmacy?
We certainly see far fewer HRT prescriptions. I think there's a reluctance in the community to take that up, and that may be media influenced, I would think.
But they're coming in for what I'd call garbage. I mean, they're coming in for stuff that doesn't work, aren't they, as well?
So sometimes they come in for other things, and again, that's influenced by advertising. So if it's on a show at night, they'll come in the next day. But sometimes it's reading and things like the internet. People are looking at that sort of resource.
Something natural and, in quotes, safe.
Natural's interesting, and personally I don't subscribe to that because it conveys certain messages, and I think they're marketing messages that natural is safe. So poison ivy is safe, but it doesn't mean that you're going to put it on your skin. Sorry, poison ivy is natural, but it doesn't mean it's safe.
Yes.
Yeah.
Christine, is menopause drifting later, earlier? I mean, menarche is going earlier, isn't it? So
yes.
You'd expect the ovaries to get clapped out earlier and menopause to come on earlier, but that's not happening, or is?
We're not cars. Look, I don't think that.
But you've only got so much fuel in the endocrine tank.
That's true. I don't think that we are seeing an increasing number of women having natural menopause earlier. But there is a difference with premature ovarian failure and early menopause, just in the sense that there are more women who have had breast cancer, had chemotherapy, maybe had surgery to remove their ovaries. So there's been quite a substantial increase in the numbers of very young women experiencing menopause. In terms of other issues, nutritional status seems to be very important, but because we are all very well fed now, we don't have menopause perhaps quite as early as some of the in centuries past.
Given, well, I mean, that's an interesting question. I mean, Liz, given that fat cells produce estrogen, do you have fewer menopausal symptoms if you're fat?
Well, in fact, I think it's the opposite from my understanding, is that in fact obesity is one of the risk factors for symptoms in menopause.
Oh, really?
Yes, but don't ask me why.
So it's counterintuitive metabolically.
It is,
given
absolutely.
that they've got more estrogen coursing around.
Yeah.
Christine, what about the stages of menopause? I mean, my impression is that's quite artificial, because this can be a prolonged project, if you like, for women.
Yes.
And what's your view of the stages of menopause?
Well, it's interesting that you should ask that, because I think that the experts are now looking at the stages of menopause in a scientific sense, and there has been for some time the straw staging, which is now being revised. But that's quite artificial, really. In terms of practical usage for clinicians, it's useful to think of premenopause, which is the time when your menstrual periods are still regular. Perimenopause, when they start to change, which is average age about 47. And then postmenopause, when you haven't had a period for about 12 months. That's the definition, in a sense. Of course, that may be retrospective. That is retrospective usually, unless you've had a surgical menopause.
What myths do you think there are amongst clinicians, Liz, particularly primary healthcare clinicians still?
That there isn't any that HRT still has quite a bad name in terms of prescribing at the general practice level, and I still think that there are some primary health physicians out there that are actually scared or too concerned to prescribe it, even to women that probably do need it. I think there are some myths that every woman is going to have a horrible menopause. And in fact, about 70% of women breeze through menopause without too much of a problem, and it's probably about 30% that I call the vocal minority that actually give menopause a bad name, not because they're not suffering, but because they tend to talk about it a lot more because it's an unpleasant experience for them.
But it is an unpleasant
Absolutely.
experience for those women, and they probably do need more help, and maybe they have to become vocal to overcome this reluctance to prescribe
That's
HRT
true, but also
by some
thinking
doctors.
in some ways that then for those that don't actually have the symptoms, they're getting a bad message about it as they lead in.
Yes.
I think it's
And Jenny, what myths do you come across amongst women?
Certainly the same as what Liz was talking about, but I also think that a lot of women think that it's going to be a bad time. And I sometimes see women that have had absolutely no symptoms at all, and they'll come in and
They
say,
wonder what's wrong.
Yes, well they do. Their periods have just stopped and they've had no other symptoms, and they're thinking, well, is this it?
Yes.
And they're the good ones.
And from a pharmacy point of view, do you see many myths?
No, not so much myths, just a reluctance to take up HRT. But I wonder whether there's a cultural influence in terms of what women expect. Are they expecting to accept that part of their life? Is that what their cultural
just
sort of
fed up.
aspects? Yeah.
Telling somebody because nobody's listening. Wasn't there studies in Japan of Japanese women that used to think that that's where the sort of soy myth came
Yes.
from, that
Yes.
Japanese women didn't have the menopause. It's just that they got fed up complaining about it to male doctors. That when they looked, they did have menopausal
It may
symptoms.
have been that, but I think there is quite a cultural influence in managing menopause, or in women's acceptance of menopause symptoms. I know that in some cultures there's no word for menopause, for instance, and it's just accepted that you get to that point. I have worked with doctors from Thailand who told me, a doctor from Thailand worked with me for a while, and she said, I can't believe how many Australian women have libido problems. It's not a problem in Thailand. Women are very happy that their husbands are not interested, or they're not
bothering them.
interested. So I don't know if that was true, but there are cultural differences.
Do we know anything about Indigenous women and how they're experiencing menopause?
Well, my experience is actually in the very, very remote communities, and certainly in all my time, I've really haven't had anybody come in complaining about menopausal symptoms. Certainly perimenopausal heavy periods and a little bit of irregular bleeding, but in terms of symptomatology, I really haven't come across that, and I'm not quite sure whether that's just because of the community perception, or perhaps because by that age a lot of the women have got a lot of other health problems going
other
on.
Things
So they've probably got other things to think about.
And in Tamworth, are you, Jenny?
I think from what I see of Aboriginal women, it's very often that they just don't report the symptoms. They often do have them, but unless you specifically ask them about their symptoms, they very often just don't report it.
Yes. Well, I've had experience in Dubbo and Coonamble where I was doing clinics with Aboriginal women, and I agree with Liz, they tend not to present. But if you actually put on a program designed around reproductive and sexual health, and maybe specifically about women's problems, they will actually come and talk about it. And I did have a woman who was 70 and an elder who I was able to ask about her experience of menopause and their experience of menopause, and she told me that she had no idea the periods would stop, and when they did stop, she thought she was going to die.
Really?
Yes, she had no idea. So that was quite interesting, because I had asked about bush medicines, and in this particular area she said she had no knowledge of any bush medicines.
Now, I thought another myth was that there's a sudden uptick in the risk of cardiovascular disease with menopause, and that British research had shown that in fact the rise in the risk of cardiovascular disease is steady in women, and there's no increased risk in particularly around the menopause. What's your take on that?
Well, I haven't actually read that particular information. Where we're at the moment, as far as I can tell, is that we know that women past menopause do have an increasing risk of cardiovascular disease, and of course women tend to present differently to men with more chronic illness. And the more recent information about HRT is that there's probably a critical window of opportunity. So if you keep the estrogen,
but that's estrogen
going.
only. It's not estrogen plus progesterone.
Well, I think that there is some data about from the WHI itself when they've done subsets of the younger women that actually seems to indicate that may be true in
if they had a burst of HRT
in combination therapy too.
I mean, Jenny, what are the symptoms that are recognised to be pinned to menopause?
Hot flushes, vaginal dryness, tiredness, irritability. Their periods can become quite irregular, heavy, lighter. Night sweats are certainly tied up often with the hot flushes, irritability, and often, one of the ones that we didn't really talk about a lot before was muscle aches and pains, and that seems to be something that has probably been underreported over the years.
Liz, are the muscle aches really truly due to menopause?
Well, they seem to respond to estrogen, and I guess that's the biggest
convincing
test.
sign.
Yeah,
yes.
that's right, exactly. If they have them and they get better when they take estrogen, and then they come back again when they stop their estrogen, then that's fairly good evidence to support that.
It has come up in at least one study as being valid.
That myalgia is a definite issue. And do we know what the factors are? We mentioned obesity a moment ago, but Christine, what the factors are that make the experience of symptoms worse?
Well, it's difficult to know exactly why some people have really bad symptoms. We do know from the Melbourne Midlife Women's Study that symptoms usually last for about 5 years, but about 23% of women or so will go on having flushes significantly for about 13 years. What makes it worse for some women than others? I don't think we know the answer to that, but maybe in amongst that, coping mechanisms, problem solving, anxiety and depression.
Other things going on in their lives.
Yes, there's often elderly parents, children moving out of home, back again.
And the libido story, because HRT doesn't do much for your libido.
The libido story is a difficult one. Again, that's really multifactorial. We now know from Susan Davis's work that testosterone levels don't significantly drop across the menopause transition, so just simply replacing testosterone probably doesn't do anything, or it may do something, but it's not the answer. I think it's really important to look at...
Although she did show in randomised trials of women with low testosterone levels that you do get
some
one or two
improvement.
extra sexual
That's right.
episodes a month, and
Yes.
they're higher quality.
Yes.
But if you actually look at the fall in testosterone, that's actually linear from the mid-30s, I believe, so that there's no
Yes.
significant drop to account for that significant fall in libido. And in fact, the closest association was with the fall in estrogen.
So testosterone wasn't the answer, I guess, is what I'm saying.
But it does point to taking the whole woman approach
It
rather
does,
than just
it does.
focusing on the hormones.
And the couple too. I mean, we've all met the woman who had terrible libido and then lost her partner through divorce and found a new, younger model, and suddenly libido's
flatter
back again.
abdomen
And pecs.
That's right. So just talk to me a little bit more about early menopause. How do we define that, Liz?
Well, early menopause, there's actually three definitions of menopause. One is premature menopause, that is women that are outside the normal range, and that's some women who become menopausal prior to the age of 40. The incidence of that's about 1%. Of natural menopause prior to the age of 40. Then you have early menopause, which is defined as menopause before the age of 45, and late menopause after the age of 55. So probably the women aged 40 to 55 are actually are still within sort of a normal range, but just outliers within that.
And what are the risk factors for early menopause? What are the causes?
For premature
Apart-
premature menopause.
I mean,
or
apart
early
from obviously oophorectomy.
So early premature menopause. There's a number of things that you need to exclude in women. There's certainly a higher. One hypothesis is that there's actually an autoimmune type cause for it, so that women who have autoimmune disorders such as thyroid dysfunction, diabetes, will have may have a higher incidence of premature ovarian failure.
So if they've got premature ovarian failure, is that a sign that you should be doing a fasting blood glucose and a thyroxine level?
Absolutely. And
Or a
probably,
TSH?
and screening for other autoimmune disorders as well. Certainly chemotherapy and radiotherapy are common causes in women that are diagnosed and treated for breast cancer under the age of 40. And also a rarer one is actually some chromosomal abnormalities which may present with premature menopause. So women who are Fragile X carriers,
Really?
and women who have, say, mosaic Turner syndrome are also at risk of developing premature menopause.
Mosaic Turners?
Mosaic Turners, and because Turner
So do you do chromosomes on people with...
Yeah, premature menopause, yeah, we do.
I mean, what difference is that going to make to your management?
It's not going to make any difference, but in terms of genetic counselling, certainly for a carrier of Fragile X, that may have some implications for certainly family.
What other
Turner syndrome, no, it won't make any difference
No.
to the treatment, but it's probably good for the woman to know.
What other investigations would you be doing, Christine, if you've got a woman with menopause earlier than you would expect?
Well, there's a number of issues to look at. Firstly, there's a psychological aspect to this, a psychosocial issue where somebody who's much younger than the normal menopause age will find it pretty difficult. There's the issue of pregnancy and fertility, whether she's had children or not. As Liz has said, sometimes this is an autoimmune phenomenon, and so that women do occasionally spontaneously ovulate even a few years down the track. So putting them on the pill if they haven't had a child may treat their symptoms and preserve bone.
Prevent an unpleasant little surprise or a pleasant one.
Well, yes, but if she still wants to have the opportunity to conceive, then HRT would be the way to go. But bones
Doesn't
are...
that increase the risk of undescended testicle in the newborn baby?
Well, now you're telling me something.
Stop it when they become pregnant.
Right.
But bones
won't go there.
would be a very important thing, and maybe cardiovascular disease too.
And you can get a DEXA scan under Medicare if you...
I believe so.
Absolutely. If you're younger than 45 when you have menopause, you are entitled. Well, you can get a rebate for a bone density.
So there are emotional issues here. I mean, this could be a strong sense of loss for some women. And in fact, we've got a a question from Paul from Coffs Harbour, who asks, has the increase in the use of fertility drugs, and presumably we should ask assisted reproduction here,
Absolutely.
had an influence on either the onset or menopause, or the experience of menopause, or confusion with menopause?
Look, I don't work in that area at all, but from my knowledge, no. I don't
I'd have
believe
to
it
say
has
that
or-
while I'm not actually answering Paul's question, I don't think, but the whole issue with assisted reproductive technology and fertility is quite a challenging one, because many women are delaying childbirth now. They're not having a child at the age that we would have in the past. They're leaving it too late, but there's this perception that ART will solve the dilemma for them.
And presumably you could have menopause starting around the time you're having ART, and that just confuses the whole situation.
Well, they just don't respond very well. So sort of women over 40 who have ovulation induction, they just don't get very many eggs, and those eggs that they do don't necessarily create good quality embryos with a high.
So those
chance
women are
of
usually
fertility.
looking at donor eggs.
Yeah, once you hit certainly
Yeah.
42 or 43, the chances of getting pregnant using, say, IVF and ovulation induction is very low.
Can I just ask about what you would recommend for women who are on the pill and they're approaching menopause years? When should they stop? Can they go through menopause without feeling anything?
Well, it can be quite a challenge, because we tend to keep taking the pill, or using contraception, but the pill in particular, until a woman's about the average age of menopause, provided she hasn't got any contraindications. So about 51. But you don't know then whether she's actually gone through menopause, because the pill will mask that.
Yep.
So you're left in a tricky situation. Somebody who doesn't want to get pregnant, in an ideal world, you move them to a barrier method of contraception and actually see what's happening with their menstrual cycles.
And of course, a woman with a hysterectomy wouldn't know when she's had the when
That's
she's actually
true.
menopausal.
Well, sometimes they do, because they can still become quite symptomatic. They can still get all the same symptoms.
But they don't know when they're actually
But they don't
hit
know when
the menopause,
period-
the
By
365
definition.
days
No,
since the
that's
last
right,
period. And the causes of a late menopause?
Well, most of the time I think it's hereditary. So that if women come in having, say, menstrual problems or symptoms, but are still menstruating, usually ask them at what stage their mother and their sisters had menopause, and that's often quite a good indicator.
And is there anything a general practitioner should be looking for in a woman who's had late menopause? I mean, she's got an increased risk of breast cancer, hasn't she?
Yes, she does. And that risk, I believe, is about the same as a woman who continued on HRT up until that time. So.
Yes, I find that quite a useful fact to discuss with women who are anxious about HRT. So if you've got a woman who's between the ages...
It's like an extra year with periods.
Yes.
And a year in HRT is like an extra year with periods.
Exactly, and they're taking the same hormone that their ovaries would normally produce, so they've got the same risk of breast cancer as a woman who has a later menopause.
And that's good to say to women who also have early menopause prior to the age of 45, but not under 40 as well, who may be concerned about going on HRT to get them through.
Let's go to our first case study. It's Rebecca, who hasn't any children. She's 40 years old. She's fairly light framed. She's pretty fit. She comes to your pharmacy, Demetra, and asks the pharmacy assistant for something herbal for her sleeplessness and her day and night sweats that she's been having. And she's heard that valerian and black cohosh are absolutely terrific.
Yes, some people believe they are, I'm sure. She may see a pharmacy assistant and may see me, depends on who she hits first, but if she sees a pharmacy assistant, they would be trained to triage, essentially to obtain as much information for her about her symptoms and her issue, any other medication she's on, any other conditions she has, and then she may have requested a product and they would come and then refer to the pharmacist to see her. So all pharmacy assistants should be trained in that in the first instance, and they wouldn't necessarily take that query on their own. I would see her and then I would ascertain whether I think she actually has menopause, because she sounds like she's come in with that preconception, and she may or may not. She may have other issues going on, stress related and otherwise. I might recommend the valerian to help her sleep in the interim until she sees her doctor.
Does it work?
I would certainly, some people say it does, some people say it doesn't, and
What is it?
it's a
Just a herbal?
For herbal complementary to help you sleep.
And
some people claim it's fantastic and some don't. And I can't say I've tried it, so I don't know.
black cohosh has got a pretty bad reputation for liver damage.
It depends on who you speak to, and the reputation has come from the incidence of liver failure. There have been incidents that have happened very immediately, so within a week of taking it. Some have happened after 3 years of taking it. And TGA has altered the requirements for the CMI for those products to include warnings on liver failure, and it's incumbent on the pharmacist to warn people who buy that that's a possible concern for them. And again, there have been some studies to indicate that it does work, but the consumer does need to be informed.
Yeah, there are also studies that show that it doesn't work particularly much better, because with all these studies there's always a huge placebo effect, and my understanding is black cohosh is not that much better than placebo, if anything.
I think there is a problem here in that people think this is a natural product, and that's why they're accessing it. And the fact that there are such severe adverse effects with it
And that's irreversible liver failure too.
Yes.
That's liver transplants, that's right.
So women are anxious about HRT, but they're prepared to go to something that they think is natural. So it's one of those really tricky and controversial areas.
But while we're talking about that, I mean, there are some pharmacists and prescribers who are pushing so-called bioidenticals and tailored, personalised treatment for your hormonal symptoms, and women are deluded into thinking that's going to be safer too.
And I think that comes from their belief in that it's the equivalent of what their body makes compared to having, a mare equivalent estrogen. And some of that may be marketing, some of that may be trial and error. Certainly there are issues.
But isn't it just a money-making exercise on the part of pharmacists?
Well, it might be, but there's a huge
it's an
polarisation.
Industry.
It is an industry, but you can argue it's no different to the industry of HRT. Like 15 years ago, I attended a lecture on HRT, which advocated that every woman should be on HRT for the rest of her life. I distinctly remember that, and that was a position
that was true. We did talk like that,
and stuff does change with new.
Yes, we did talk like that, but we do now know a lot more about HRT and who's the best person to use it. And I think one of the issues around the bioidenticals is that women are sort of lulled into a false sense of security that this is safe. If it's actively working, if it does contain the natural hormone, then it's got the same effect as the natural hormone, which, as we've just said,
you don't get one without the other.
You can't get one without the other.
And you're not TGA protected here, so these are not registered products.
No, they're not registered products, and if a doctor is prescribing them, and so some people are very passionate about it and believe that they know exactly what they're doing, and that's that's what they're doing. But there are other doctors who get asked to write prescriptions for patients because they don't go back to the first one. And
because of the expense.
Yes, because of expense. And the legal situation is that doctor is actually responsible for writing that recipe, if you like, which is what a prescription is, and they take on the responsibility for the effect on the woman. So if there is a very nasty untoward effect, it's not a company that's liable.
So has there been any litigation of women developing breast cancer suing for these bioidenticals?
Not that I know of yet, but there have been some cases of endometrial cancer that have been reported to the TGA, and we've asked them to look into it.
So these women have been given a bioidentical of unopposed estrogen?
Yes. Or progesterone, because oral progesterone is not, or progesterone creams are not as well absorbed. So you don't actually know what the endometrial protective levels
So the progesterone becomes the issue, is that you're giving it in a form which is not necessarily effective.
That's right.
Or dose there. So you think you're giving opposed estrogen, but you're not.
Yes.
Well, there's also, the dosage factor, from what I understand, in some instances where, you massage it in. So how much do you massage in? There's those things that need to be controlled, and they're not.
And they are controlled in commercial situations where pharmaceutical companies are under scrutiny, and they have quality control, and we know what women are getting. It doesn't mean to say that there aren't some adverse effects, but at least we have a good concept of what they are now, and we have a good evidence base about them.
So buyer beware here. Now Rebecca Demetra refers Rebecca to you, Christine, for further management.
Thank you, Demetra.
My pleasure.
And you find out more that she's excessively tired, that she gets these hot flashes, she's not sleeping very well at all, her mood is swinging around, and she gets increased anxiety. And you find also, when you ask about her adolescence, she had an eating disorder.
Okay. Well, I think one of the most important things here is to assess whether she actually is menopausal or not. So rather than leaping into doing FSH, I usually would like to get a picture of her menstrual periods and whether she's actually had amenorrhea. But it's equally important to get the story, for the woman to tell her story, hopefully uninterrupted if you've got the time, so that you can get a picture of where she's at, so you can validate what she's experienced and give her information and normalise it. Given if she is truly somebody who's had amenorrhea for a while and she's got these symptoms, then she probably is early menopausal. It may be useful to do an FSH in this instance because you need to prove to her and possibly to yourself that she is, although because she's young. And you need to be aware, though, that FSH can vary, and if she was about to ovulate, again, she may.
So you need to know where you are in the cycle, which is hard if she's got irregular periods.
Sometimes you just need to repeat it a couple of times. Yeah. Like if you do it and it's high, and then 2 weeks later she gets a period, then you know.
But doing estrogen levels are a waste of time?
Pretty much, yeah. I wouldn't,
because they vary
wouldn't
too much.
normally do them.
No.
I know that women come in asking for hormone levels to be done, and in her case, a young woman, it may, you've got to look at things like prolactin, etc., whether there are other causes for this. But if we have got a straight case of early menopause, then it's important for us to look at her psychological profile, what's happening for her, because this is likely to cause grief, fear, anger. Fertility, has she had a child? Does she still want a child? Is she in a relationship? I do get a number of women who decide actually at the age of 40 that they're going to have a child, whatever happens. And then bone, she's certainly in the age group where bone may be a problem. And given that she had an adolescence or early 20s anorexia or some eating disorder, she probably had amenorrhea for 6 months or more. That puts her at higher risk. That's another rebatable DEXA story if you've had hypogonadism for 6 months or more.
And what about if she says, I was an elite athlete and played netball for the state and didn't have periods for 3 years in my late adolescence. Does that qualify you for a DEXA?
Yes. Basically, she didn't have. She was definition of hypogonadism, even though she would have been exercising like mad.
I was just the only other thing I was going to say, just coming right back to the hormone levels, was if this lady does have normal hormone levels, that still doesn't exclude that she's actually heading into the perimenopause either. You don't need an.
But would you start to investigate her for PUOs or some hidden malignancy?
Oh, absolutely. I mean, I would probably, unless she, I would. I'd certainly be doing, certainly thyroid function and screens for diabetes.
Yes, some of those.
Certainly a full blood count, screens for chronic infections.
They might not do her bench Jones proteins just yet.
I don't think I would. I think if I had all of the other things, but certainly thyroid function would be worth checking.
And certainly, hot flashes, another rare cause would be, say, a hormonally active tumour such as a pheochromocytoma.
Some people say that premenstrual syndrome is associated. So women who complain of symptoms around the time of the menopause, around the time of menstruation, do worse with their menopausal symptoms. Is that true?
Well, it's certainly been reported in a number of studies when they've looked at it. Now, whether or not what the relationship is difficult to define, and it may just be that women who suffer from PMS actually have a higher sort of baseline anxiety and depression score, sort of lower low abilities to cope. But it's difficult to generalise in that way.
It may be that tipped over the edge a bit more with hormones too.
Yes, that's right. It's more hormone sensitive.
This is an area that's so hard to understand. I know Lorraine Denistein's done many studies on PMT, and I think she basically says that it is a pretty hard area to study.
She was the one who found out that a new partner is what
Absolutely.
sorts out your libido. Watch out, you men, you've got to perform. Jenny, what do you do in this holistic sense for women? People talk about lifestyle changes, diet changes, nutrition, exercise, those sorts of things. What's your practice with women who come in and want a more holistic approach?
I certainly talk to them about the sorts of things that might be increasing their hot flushes. Talk to them about cutting down on their alcohol intake, for instance. We know that red wine can certainly make flushes worse, particularly at night time. We know that their higher anxiety levels and depression can certainly make their symptoms a lot worse. So just looking at those general lifestyle things, stopping smoking if they haven't already, and hopefully they have stopped smoking, but a lot unfortunately don't.
Because that is a risk factor for increased symptomatology, isn't it?
Look, I don't know so much about the symptoms. Is
Yeah, I
that
believe it
Yes,
it
and
may
also
well do.
bone density.
and early
Certainly,
menopause.
yes. We know with the earlier menopause and the bone density and cardiovascular risk, then smoking's obviously way up there. I wasn't really aware of whether it actually makes your symptoms worse or not.
Well, I think because it probably vasodilates to some extent, you do get worse vasomotor symptoms, a bit like taking alcohol.
So have there been
Absolutely.
studies of exercise, diet? Do we know whether they make a difference?
One of the things I did, sorry Christine, one of the things that seems to be fairly well known is spicy foods. That's one of the things that we know can certainly cause hot flushes, not cause hot flushes,
in
but
me,
it
so
makes
why
them...
wouldn't it in a menopausal woman?
So another thing that we would say to them, as well as cutting down on that red wine and so on, is maybe looking at their food and
Taking all the fun out of life.
moving back a
Yeah.
little bit from the spicy food perhaps.
What about exercise?
Well, there have been some studies. There have been studies that have looked at all aspects of menopause: exercise, acupuncture, meditation, mindfulness. It's hard to come up with a randomised controlled trial that proves that they actually do anything, but they probably do more good than harm.
Well,
They
exercise
are-
would help your depression.
Exactly. And my approach to managing menopause is to try and empower women as far as possible to deal with it themselves, with some help from me and from the nurse that I work with and maybe the counsellor, but looking at the whole woman and encouraging her to take charge. So yes, I'll get down on the floor and show her some exercises if she thinks that it all takes too long. Get her out and about, looking at what she can do with her brain. You know, many women have put their lives on hold because of children. And I had a woman the other day who certainly had lots of problems to deal with, a husband with cancer and an elderly mother and children at high school. And once we kind of unpackaged that a bit and dealt with some of her problems, she started to think forward. And she was planning on taking up a university course and doing some dance classes. So, you know, all that's important.
Suddenly there was more to think about than symptoms, more to do. Who merits HRT in this day and age, Liz?
I think women whose symptoms are quality of life impairing. So that is women that find that the symptoms that they're getting are interfering to the point where they cannot undertake normal activities in a good frame of mind. Yeah.
So what's available now? Because some stuff has gone off the market, some's not available in the PBS, and how do you start? I mean, I would imagine some GPs, particularly rural GPs who haven't prescribed for a while, might be feeling a bit de-skilled about starting.
Absolutely, and certainly if they go to the menopause, Australasian Menopause Society website, there's actually a list of HRT that's available, whether a list on the PBS, the different forms that there are available, and that's a very good resource, because the biggest change that's happened over the last few years is that a number of preparations, particularly oral preparations, have been taken off the PBS, so that especially for women that are on the pension, the drugs that are now, or the hormones that are now available to them, are really quite limited. And so
it's patches?
It's patches. Well, estradiol implants have just, Merck Sharp and Dohme worldwide have just stopped production of estradiol implants, so they're no longer available. And number of different preparations, oral preparations, have actually been taken off the market, and then those removed from the oral tablets. So really, yes, we're down to patches.
So tell me about dose finding, because that's been an issue in the past.
Dose findings is very...
So you haven't had a hysterectomy, you're going on a combined HRT.
Now there are some combined patches available, but that very much limits you to the dose, in that there's only a fixed dose of 50 micrograms of estradiol in those combined patches. Whereas if you just use the other estradiol, like estradiol patches without the progesterone cover, then in fact you have a range of 25, 37.5, 50, 75 and 100 microgram patches, so that it's a lot easier to titrate the estrogen. But if you do that, then they've still got to take an oral progesterone or have a Mirena or look at something else to give them endometrial protection. So usually if a woman is coming up to menopause and is getting symptoms that she feels that she would like to take HRT for, usually just start her on an average dose, and that would be the middle of the range, usually 50 micrograms of estrogen with appropriate progesterone.
And is the progesterone tethered to the estrogen, or is it a standard dose?
With the patches, there are two doses.
There's two doses. There's 140 and 250.
So it's already sorted out.
If you're going to customise it, you'd have to give an oral progesterone or a Mirena.
Yeah, and I think if you lower the estrogen dose, you can drop the progesterone dose.
And the other thing, Liz, is about starting women when they're close to menopause. We generally use sequential or cyclical therapy, and then later
on... What does that mean?
Well, it means that they're going to get a period every month, essentially.
So it's like a pill, but it's HRT.
Well, there's two different types.
Similar.
Yeah, there's one where you get estrogen and progesterone for the whole time. So every day or every patch contains both estrogen and progesterone, and then there's ones where you use just estrogen only for 2 weeks and then progesterone for 2 weeks, and those women will get a period when they get the progesterone withdrawal.
There's evidence to support that?
Absolutely, because if you start women on HRT when they're still perimenopausal, when their ovaries are actually still producing some estrogen on their own, HRT is not strong enough to actually suppress that, and they will get a lot of breakthrough bleeding. So that if a woman is not 12 months after her last period, you should start her on cyclical HRT.
And side effects?
Periods.
Yes. So breakthrough bleeding.
Breast soreness?
Breast soreness. No, well, if you start them on cyclical estrogen, then usually that usually controls the breakthrough bleeding.
And what about weight gain?
Weight gain? Well, weight gain, I think the evidence is when you hit middle age, you put on weight. Women on HRT blame the HRT, women off the HRT blame not being on HRT, blame the lack of hormones, and in fact the problem is it's just an age thing and a change in your metabolism.
And the story's different. If a woman's had a hysterectomy and she's on unopposed estrogen, the story is quite good there. I mean, there's no increased risk of breast cancer, I understand.
Yeah. That has been supported by the WHI trial, the estrogen only, the WHI trial, and I believe there's been another trial or two after that that's also supported that.
There's quite robust evidence that women on estrogen alone are in the good group, as far as that goes.
We've got some questions here. Is there any connection between early onset diabetes and adult onset diabetes and early menopause?
Adult onset diabetes or...
So you would say it's type 1 diabetes, not early onset?
Yes, type 1, the autoimmune one.
And we've already covered another question from rural New South Wales about high level of alcohol and severe symptoms, and you were saying that is an issue. And another GP from South Australia asking, should we routinely advise against the use of bioidenticals? And we're saying really it's more a matter of yes, because you don't know the dose, and it's also informed consent because it's not safer.
Yes.
The other thing that I notice with women that have been using those is they're really not getting that good follow-up through their GP. So it's not actually being monitored at all.
Now, the Gene Health Foundation's got an algorithm, haven't they?
They do. This is the Gene Health Foundation algorithm, and it's been endorsed by both the AMS and it's in the family planning literature as well. So,
and there's patient education materials as well, which we'll have.
There are patient education materials.
Demetra's got that.
We have the menopause information leaflets for patients, and that's put out by the PSA. And there's resources on the back of that, so all the Gene Health Foundation contacts, Menopause Society and other resources are on their phone numbers.
And the Australian Family Physician's got quite a good... So the Australian Family Physician has a whole edition on menopause,
Very good resource for GPs.
Now, there's been a bit of controversy with vitamin D and calcium. Some New Zealand researchers suggesting an increased risk of heart disease, but the evidence is fairly strong for vitamin D and calcium.
The heart disease one is in women taking calcium alone, not with vitamin D, and my understanding is that the vitamin D negated that effect. Anybody else want to say anything?
I know osteoporosis, if people are concerned, they can go to the Osteoporosis Australia website and they've got a statement about calcium.
Yeah, although there are guidelines about to be finalised in about in a month or two's time. And really here, Jenny, learning about your symptoms and knowing how to look after them yourself is critical here.
Definitely, most definitely. The other thing that I would suggest to women is a lot of women these days have actually got access to the internet. And the Jean Hales Foundation, for instance, has got some really good fact sheets specifically for those women. So I always direct them to those sorts of websites. Absolutely, and they are actually the only two websites that I ever recommend that women go to get some good information. The Jean Hales Foundation also puts out a quarterly, I think it's quarterly magazine, free of charge. Women can just actually phone in or write in and subscribe for free, and it's got some really good basic information around menopause.
Yes, and I think it's worth mentioning, we did talk about early menopause, premature menopause a bit, and Jean Hales does have a support group.
Yes.
Because that's
an online support group.
I'm not sure exactly how it works, but I think they have a newsletter too.
Let's go to our next case study. Sophie, who's a married woman of 54, living on a farm in Western Queensland. She's menopausal, she's still sexually active, but she's upset. She's progressively experienced a loss of libido. She complains of vaginal dryness and some pain with intercourse. She has signs of weakening bladder control, a little bit of urinary incontinence, and her adolescent children are growing up, not adolescent anymore, leaving home, and she's caring part-time for an aged parent. She's becoming anxious, depressed, mood changes, complains of feeling unappreciated and unloved, and she comes to see you to begin with, Jenny.
It's a very common presentation, and this woman has a lot of things going on in her life, so she needs to have a holistic approach to what's happening. Obviously, her symptoms need to be controlled, but I would be looking at her as a whole. As Christine says, I'd certainly be listening to her story and not trying to solve all of her problems at once, but taking it bit by bit and hopefully making things better.
What would you do about her bladder problems, Liz?
Well, I think you need to get a history off her. There's two sorts of incontinence. There's what we call urgency and urge incontinence, that is the gotta go, race to the toilet problem, versus the stress incontinence, the weakness of the pelvic floor and
does that often come on at menopause?
Look, it's more common. It's more common at menopause, just as it's vaginal prolapse is more commonly presents in women, as they hit menopause and beyond, and that's just because I think the as you get the fall in estrogen, you get the vaginal atrophy, the ligamentous laxity, any weakness that was there that was held up by the good tissue turgor, as the tissues become weaker, just tends to sag and give way. The other thing is that the parts of the urethra and certainly the bladder trigone are also estrogen dependent, so that as the estrogen levels fall there, sometimes that can become just more sensitive.
But again, HRT wasn't very good at that, from memory.
Well, I think my understanding is the results were mixed. So in a lady like this, if say she did have urinary urgency and frequency as her main presenting problem, I actually would try her on HRT. Now sometimes that makes it worse, but sometimes it actually does make it better.
But presumably not instead of bladder training or pelvic floor training.
I would still do that as well, but she's also got the dyspareunia, so that will help with both of those problems. But the difficulty for her is going to be that she's out in Western Queensland, and I think if you're going to do pelvic floor exercises, there's good evidence that actually working with a good women's pelvic floor physio actually is better than doing it on your own. But the question is with access for her, and while I live in Canberra, it's great. I've got a few really good women's health physios with particular interest in women's pelvic floor. Once I start to deal with women, say from the South Coast or inland New South Wales, where they've just got the generic physio that does ankles and arms and backs, and often they're men and just not that interested in pelvic floors, and it becomes very difficult. But if she can possibly get to a good women's physio, then I think she will be better off, because certainly as she gets older, your pelvic floor does get weaker, and it's best to keep it as healthy as you can from as early as you can.
Can I just say that I agree with you, absolutely.
But now you're about to disagree.
No, I'm not about to disagree. I'm actually about to just say that what I do in a practical sense, because I'm not a super specialist like you are, is to get the women to use vaginal estrogen to do their pelvic floors, and if they are overweight, to try and lose weight, and give them a 3-month window of doing this fairly consistently, and hopefully get a nurse or a physio to show them the exercises so they do them correctly, and then get them back in 3 months just to see. And we don't always expect perfection, but I often do find that women then have it a bit better under control, and they feel more in control.
So you'd go straight to vaginal estrogen for her vaginal dryness?
In somebody like that, I would.
Yeah, and I would too, actually.
And the other thing with this
Is there
particular
any risks
woman...
of endometrial hyperplasia with vaginal estrogen?
Studies that have been done over at least a year indicate that not, although I have had some women, and probably some of the GPs out there will say the same, who have used it according to directions and have had a little bit of bleeding. So clearly from time to time there is a bit of absorption.
Do you think that that's bleeding from the uterus or bleeding from trauma from pushing the thing in? Because my experience is sometimes they scratch themselves.
I think there are some women who genuinely have a little bit of bleeding because they describe a sort of heaviness, a bit like a period bleeding.
And is there truth to the assertion that if they continue being sexually active, the vaginal dryness tends to sort itself out?
Look, vaginal dryness comes on often 4 to 5 years after menopause, and it can be quite progressive, and it can be very distressing for a couple who've had a good, healthy sex life all their lives. So using lubricants and moisturisers is important, but sometimes vaginal estrogens are the only way, and they will need to use them long term. But I generally try and get women to use them for a couple of weeks to sort of prime the vagina, then twice a week as directed, but then even say you might get away with once a week or even once every 10 days. Try and monitor it yourself.
And there's an issue in terms of cervical cancer screening for doing pap smears.
Absolutely.
That really helps to do the pap smear.
Well, if women are getting atrophic smears, then yes, that definitely helps.
And not only that,
but it's hard to do the actual speculum
absolutely.
examination
Yes.
in a woman who's got a...
Actually, when I was at family planning, we did a study, Deborah Bateson ran a study on that and found that 5 days of estradiol starting 7 days prior to the pap smear was perfect, and we actually had the pathologists look at the specimens, and that was the
But did that actually reduce the pain associated with having the pap smear as well?
We did acceptability and
pathology. 2 to 3 days beforehand, ideally.
Why is that?
Well, that was just the dose-finding study. That was just
no particular reason why you should start. Oh, right. Okay.
Yeah. So well, starting 7 days
We're happy to provide some education for you here, Dr. Gallagher.
Thank you.
Well, this is just totally practical stuff.
Now, I mean, Professor Sue Davis, who we've had on the programme before, would say, why wouldn't you consider testosterone? I mean, her randomised trial suggests that there is some benefit here. I know it's not approved in Australia.
Well, from my perspective, testosterone's not, as you say, it's not approved for women in Australia, and it has some issues with safety. The FDA didn't approve it in the United States either. It has been shown in some trials to help to some extent. I see libido as a far more multi-dimensional problem than as a hormonal problem, and I would rather spend the time in unpacking it. However, I accept that there will be some women for whom testosterone seems to be a necessary thing.
Let's go on to our next case study, who's Katrina. She's 55 years old. She presents with heavy periods on and off for the past 6 months. She has 3 or 4 sweats a day and chills, and she's really feeling emotionally labile over the past 3 months, and she recently slipped on a stair, and it wasn't a very, she was pretty surprised because she broke her ankle, and she's really just generally quite anxious about the whole thing. Christine?
Yeah, I'd be worried about this. Having a fracture is...
Well, she's got osteoporosis until proven otherwise, hasn't she?
Virtually, yes. So we need a DEXA on her, for sure. It's important to really get a good history and to look at reasons why that might be the case. If she actually does have a poor T-score, so below -2.5 is defined as osteoporosis by the WHO, but it's not the only reason for fractures, of course. And we also, in this woman, there is also this issue of heavy periods. So a woman who's having very heavy periods sometimes completely underestimates the amount of blood she's losing. Very important to know what her hemoglobin is, what her iron stores are. You do see women who are quite anemic. And then you may need...
This is a woman that you'd want to do a pap smear on, isn't it?
Well, if she hasn't had her pap smear, hopefully... Well, you've made a very good point, Norman. When we do a menopause consultation and managing menopause, we mustn't forget about the preventive care. So, as Jenny has already said, you know, doing the pap smear every 2 years until somebody's 70, and then breast examinations through breast screen, and of course looking at holistic things like we've already discussed.
So how are you going to manage her heavy periods, Liz?
Well, I think it's important to get a good history of her. When they're saying on and off, my experience with a lot of women heading into the perimenopause is, in fact, 1 month might be heavy, the next month might be light, and you look at whether they're manageable for her. Like some women actually find that they can manage a one-off heavy period every now and then. You look at her iron levels and her hemoglobin.
She's multiple pads a day.
More than multiple pads every few hours actually would be more my definition.
My test is to ask them whether they have to put a towel on the bed at night.
Yeah, or how often they get up to change their pads at night, and how often they change a pad during the day usually.
So is she a candidate for a hysterectomy, or can you manage
Absolutely not. There's lots and lots of really good medical management of heavy periods, especially in a woman of 55 who is likely to become menopausal or postmenopausal sometime in the next year or two. So if you often put her in, well, no, but I often put it in perspective with them and say, look, you know, if you're going to reach menopause in another year, you're only going to have 12 more periods in your whole life. Do you think you can manage that? And often they can. But in terms of looking at management, then, you know, there's basically medical management, surgical management. Medical management will clean things like the pill, but I certainly wouldn't be putting a 55-year-old on it. Drugs such as tranexamic acid, which is, they can just use every 6 hours when the bleeding is heavy, will reduce menstrual blood loss by about 40%, and sometimes just bring that into a more manageable time frame. The Mirena has certainly revolutionised treatment of heavy periods in perimenopausal women.
Just remind us what that is.
Sorry?
Just remind us what that is.
It's a progesterone-containing IUD, and so that works by just over time thinning the lining of the uterus down, so that it reduces menstrual blood loss on average by about 94% for women. That lasts for 5 years. Will do if she ever does need HRT for progesterone cover, so she can just use estrogen-only patches. So that's fantastic. And then really if you're looking at the surgical management of heavy periods, then you've really got... There's the endometrial ablations now. There's a number of different forms of endometrial ablations, which are day procedures, work very quickly. Usually we'll have a good effect within about 6 weeks of having it. You'll know whether you're going to... and then move on to hysterectomy. But, you know, and certainly in somebody like her, I'd do a pelvic ultrasound as well, just to check what...
We've had a question from Christine from Rural New South Wales. What would you do with her husband?
I'd try and get him in to actually talk as often as I can. When I have women who have emotional issues as well as other important things, I like to ask them if they'd bring their husbands along so that I can get his perspective and I can get a couple perspective, because there's often, in rural areas, there's often, look, across the board, there are often a lot of issues going on in a relationship. So I'd be talking with him and with her. And in fact, men are very interested in menopause. They often don't say a great deal to start with, but once you get into the flow of it, they'll offer quite good insights. And one time I was actually invited to go and talk to a group of Vietnam veterans about menopause, which intrigued me, but they were very interested.
Good. Let's go to our last case study, who's Anne. She's 52 years old, postmenopausal. 2 years ago, she was diagnosed with breast cancer, and she comes to you with hot flashes, irritability, sleep problems, vaginal dryness, dyspareunia that isn't relieved by lubricants. She had chemo and radiation for her breast cancer, lumpectomy and chemo and radiation, adjuvant therapy. She's estrogen receptor positive, and she's on tamoxifen at the moment following the initial diagnosis and management. Liz?
Well, I think you've got to tease out all the different symptoms. Certainly there is some evidence in women like this who are estrogen progesterone receptor positive that if you give them HRT, then there is a higher chance of recurrence rates. There was 2 studies that showed that.
So this is a contraindication to HRT?
So therefore it's a contraindication to hormonal therapy, that's right. So there are a number of non-hormonal treatments for hot flushes and irritability. Before we got into drugs, we'd need to...
So this is like nifedipine, calcium channel blockers, or what?
No, not nifedipine, clonidine.
Right.
Yes, clonidines.
Yeah, clonidine, the SNRIs and SSRIs, and gabapentin are the sort of four groups of drugs that seem to help with hot flushes. They're not quite as effective as estrogen, but in a woman like this, probably just managing rather than curing would be enough.
And if she was on raloxifene for her chemo prevention, does that cause the same issues?
Yeah, both tamoxifen and raloxifene are SERMs, and that's a selective estrogen receptor modulator. And while they are very useful in managing some estrogen-related issues, they're agonists, they're also antagonists, and they do tend to cause hot flushes. So raloxifene will have the same problem as tamoxifen. So I agree with Liz that the SSRIs, etc., are probably the way to go.
But you do get an interaction, don't you?
There is an interaction with tamoxifen, and there's the cytochrome P450 enzyme can be affected, and so with paroxetine and also with fluoxetine. So probably wisest to stay away from them. But an SNRI like venlafaxine can be quite useful. About 60% of the time they help with flushing. There is the issue, of course, with this woman about her vagina and her discomfort, and a lot of oncologists would be reluctant to use vaginal estrogens, and we've already said that systemic HRT is contraindicated. But there may be a place for using a weak estrogen, like estriol perhaps, in some cases. Of course, you've got to go through the whole issue with women and get informed consent. There is no data that says we can safely use it.
So
but there is also no data to say it's unsafe.
Yes,
so
and I would always try and have a talk with the oncologist to see if we can make this woman... There's a quality of life issue here.
And of course, with the advent of regional cancer centres, there's going to be more and more local expertise available to general practitioners in rural areas. What are your take-home messages, Dimitra?
I suppose about that time of life, I think women should consider an overall checkup where they are with their pill, if they're on the pill, if they're suffering symptoms, what are they going to do about it? Do they need to see their GP to evaluate what options they have? Are the symptoms bad enough that they need to do anything?
Christine?
I'd take an individual woman approach with a holistic kind of management process, looking at all of the elements of her life and seeing what it is that I can help her with, but on an individual basis.
Liz?
I think that GPs and family practitioners should not be afraid to prescribe HRT in women who need it around the time of perimenopause, because it's definitely the best treatment. We've got good data now about the risks and benefits, and certainly short term in women it's the treatment of choice.
Jenny?
Norman, I would agree with mainly with what Christine said from my point of view, but also just to remind women that it's a very natural, normal part of their life, and that there are things that can be done for them and that they don't need to suffer in silence.
Thank you all very much indeed. It's been a fascinating programme. I've learned a lot, and I hope you have too, on this programme on feeling the heat, managing the menopause. And here are some useful sites for you to go to. Jenny, I think, mentioned some of these earlier, the Menopause Society, Jean Hales, and of course the Commonwealth's Health Insight. And if you're interested in obtaining even more information about the issues raised in the programme, there are a number of resources available on the Rural Health Education Foundation's website, rhef.com.au. There's also limited DVD distribution of this programme available, and you can check the Rural Health Education Foundation's website for details. Thanks to the Australian Government's Department of Health and Ageing for making this programme possible, but thanks also to you for taking the time to watch and participate. Don't forget to complete and send in your evaluation forms to register for CPD points. I'm Norman Swan, and I'll see you next time.